Okay, President Joyce, back to you.
Alrighty. We do have a couple of guest speakers today. The board has allowed 30 minutes with 10 minutes for Q&A for a presentation regarding SMART, which is Safe Medication for All Requires Translation, regarding 2019 SB 698 dual language labels. The presentation slides will be provided as part of the meeting summary. I'd like to introduce our guest speakers today, Nancy Louie Lee and Kristen Beers Jones. Nancy Louie Lee is a pharmacist, MS, CPHQ. Nancy has been a registered Oregon pharmacist since 1979. She was raised by immigrant parents in a Chinese-speaking household and learned English from neighbor kids at school. She grew up accompanying her parents to physician and pharmacist visits and interpreting for them throughout their lives. As a pharmacist, Nancy worked in academia and health systems for over 45 years. She served as faculty at the University of Arizona College of Pharmacy, led clinical pharmacy services for Providence Health Systems in Portland and Kaiser Permanente Northwest, and became vice president of quality and safety for Kaiser Permanente. We're responsible for clinical quality improvement, including health equity for over 500,000 members in the Northwest. She is retired and enjoys family time, traveling, serving as part-time instructor at OSU College of Pharmacy, teaching population health and quality improvement, and an advocate for improving healthcare access for underserved populations. Most recently, she joined Kristen and other advocates to improve implementation of Oregon's dual language label law. The second guest is Kristen Beers Jones, RN and MN. Kristen is a public health nurse. She worked for 9 years with Kaiser Permanente Home Health and Hospice. In 2012, joined the faculty at OHSU School of Nursing. She is an assistant professor of clinical nursing, teaching population health, health promotion, and leadership. For 10 years, her clinical students were placed with a refugee health resettlement agency where they coordinated a caseload of refugee families each term. Kristen and the students visited the families each week in their homes, assisting with medication reconciliation for their patients, led to the realization that many severe medication errors they found were a result of their patients not being able to read the English-only medication directions. This led them to partner with advocacy groups, Oregon Law Center, community-based health providers and legislators, and others to pass SMART law, Safe Medication for All Requires Translation. Kristen was awarded the 2019 Oregon Public Health Association's policy. So thank you and welcome.
Thank you very much. So President Joyce, I'm sorry, Vice President Kirkbride, and members of the board. We are very excited to be here and have this opportunity to have some, we think, enlightening for us anyway, and hopefully for you, information about this law. We've been on a journey over the last year. Kristen, as the originator of the law, I'm very happy is here, and she kind of pulled me in over the last year, and through kind of shock and dismay, myself being a pharmacist, thinking, how could we be where we are 5 or more years after the law has been implemented? So we're going to share our journey. Next slide. Our purpose today is to share some initial data and information about the status of implementation of this law, and to extend a request for partnership and collaboration regarding medication safety and improving it through application of this law. Next slide. I'm going to turn it over to Kristen to talk about why we need this law.
Yes, thank you so much for inviting us to be here today. This is a perfect slide of what my students and I encountered in our daily home visits with families who 95% did not speak English. Students are trying very hard to help this mother figure out which medications are for which member of her family. But I think it's really important to share a couple other stories that really hopefully demonstrate our vast concern about this. I had another family who they described a bomb going off in Iraq with a blue powder that was released, and ever since then, their children had severe asthma. They managed to get to the United States. The kids were in and out of the emergency room. When we went to do the medication reconciliation, we realized that the mother had not given the medications as prescribed. She was horrified. This is somebody who had a lot of education. She spoke 5 languages. She just didn't read English, and the consequences were severe. Another example I have is a young mother who delivered a baby at a hospital in Portland, also didn't speak English. I have to assume when she went down to the pharmacy upon discharge that the pharmacist called an interpreter. It was very clear she didn't speak English. I'm assuming that it's the right thing to do. It's federal law, but I have to say that I encountered many times when that didn't happen. But nevertheless, let's assume that it did. The pharmacist gave her a bag of medications. The interpreter, I assume, told her how to take them and what they were for and who they were for. She got home after giving birth, other children in the home, and could not remember what the interpreter had told her. She looks at the medications, can't read them, and she chose the safest option, which is just not to give any medications to herself or her baby. So those are just 2 examples. I have many more of pretty severe medication errors that were a result of not being able to read English. Slide. So Dr. Park is one of our colleagues in these efforts. He was with me very early on, and I'm not going to read this testimony that he gave in front of the legislature, but essentially he grew up in a family that did not speak English. He had a sister with a severe illness, and at some point it really it got so severe that her pain was out of control, and they took her to the emergency room. And his parents discovered that they had not been giving their daughter the medication to deal with the pain, and it was all because they did not speak English. I do want to. One of my favorite quotes in this journey is from Dr. Park. He says, in his 30 years spanning his families and as a provider. Healthcare has developed a wide array of medical innovations, immune-changing drugs, tiny robotic surgeries, electronic health records, and yet we have not yet figured out how to support patients with limited English proficiency to simply read their medication labels. Ryan was hoping to be here today, but got called to the hospital.
Slide. So approximately 15 to 18% of Oregonians, or 600 to 700,000 Oregonians, speak a language other than English as their preferred language at home. And a majority of these people speak English less than very well. And we do know with evidence published that for patients with non-English language preferences, it's known that their outcomes in healthcare are very poor, desperate, high cost, and poor quality, including more adverse drug events, longer wait times to see physicians. They're more likely to return visits to ED, and more likely to suffer an adverse event in the hospital. And when they do suffer those events, they usually are of higher degree of harm. And the adverse events are more likely due to the result of communication. Next slide. I'd like to ask the board to indulge in this exercise for a moment, and please read these directions. And with a show of hands, if you could tell me if you would understand how to take this medication. Raise your hand if you understand. See no hands raised. Next slide. This is the experience our patients are having. And as a pharmacist, I was just perplexed and bewildered earlier this year when Kristen was telling me about what she was encountering. I just didn't understand it. We're very compliant as professionals. We want to do the best for our patients. So how could this be happening? So my first stop was with the board to ask, is this included in the self-assessment survey? And indeed it is. But that alone is not working. So our second step, being a population health QI professional, was to find out what is current state, what is happening around our state. So we launched our journey. Next slide. Since suggested, I make a stop at pharmacy.com. The pharmacist owner there, Jasmine Nguyen, has done an excellent job providing dual language labels and bilingual services. Her population of over 70 to 80% of her patients require dual language services. She's hired staff who speak multiple languages: Vietnamese, Mandarin, Cantonese, Taishanese, English, Spanish, and Russian. Slide. She's also implemented tools to help people color coded shapes of bottles, next slide, as well as bubble packing to help people with adherence. These all include and meet the board requirements for dual language. Next slide. Biggest barrier that she identified is financial, she believes, as an independent pharmacy. The cash flow is limited because oftentimes reimbursement comes in slow after a month or so. They are not recognized oftentimes by insurance companies as providers. So the time to spend consulting on medications is not reimbursed. And the cost for language service is significant, paying for 14 languages. And typically at her pharmacy, using probably 5 regularly is in a way kind of an overpayment. But that's how the structure of the vendors is outlined. She also mentioned a challenge with indications on the medications, but I'm not going to highlight that at this point. Next slide. So what might help from a small independent pharmacist regarding the cost? For example, she pays $25 a month for 14 languages, which is $350 or $4,200 per year. Uses only about 5 of those 14 languages. And if her subscription could be focused around the 5 languages, that cost would reduce to $1,500 per year. The problem with this and why she hasn't gone to that is that adding an additional language would take another 1 or 2 days. So that would delay medications for the patients for another day or two. So she continues to pay for all 14 languages, even though she does not use most of them. So considerations for improvement are to allow some kind of pharmacies to focus on the top 5 languages that serve their community. Maybe develop an organizational leverage like larger health systems and larger chains have to purchase on a broader scale. Negotiate with vendors so that languages other than the top 5 they can get them same day rather than after 1 or 2 days. Next slide. In the course that I teach, Population Health and Quality Improvement, a couple of the students this year picked this law to deep dive into as their longitudinal project. And some of their findings include that they found in the pharmacies that the signage is posted, so it does meet the legal requirement, but it's behind a plant or around the corner. It's places where no one ever sees. Interpreters are used quite often, and that can seem to be a problem. But pharmacies are challenged because there is not sufficient bilingual staff employed. The documentation of a patient preferred language is also less than optimal at this pharmacy, 78%. And it's great though that the team set a target of 90 to 100% documented preferred languages in the 2 months of the course. The quality of the translated SIGs that the pharmacies are using are problematic. One student was asked to take on a project to translate a pharmacy's in-house translations, and he found multiple errors that were identified and they were subsequently corrected. If he had not done his project, those bilingual information would have been continued to be used. So the tests of change during the course through June were completed, but we don't have data on the impact of on medication adherence or alternative reduction in use of healthcare. The pharmacists that these students worked with were all very receptive to the QI work around this law. They stated that without having their students, they would not have addressed this QI work. Next slide. In August, we were invited by the Asian Health and Services Center to speak to their community health workers that serve across the state, patients that speak Korean, Vietnamese, Mandarin, and Cantonese. There were 25 community health workers present, and across the board, they were not aware again of this law. Their suggestions for improvement are to have more prominent signage in the pharmacies, that providers should specify on their prescription order that the patient requires dual language and make it part of the order. And the pharmacy computer system should carry forward the preferred language rather than having to repeat it each time. Next slide. In October, our partners at the Oregon Health Authority provided information to their Community Health Engagement Office. And they covered 3 areas: Washington County, Columbia County, and the Columbia Gorge, Hood River, Wasco, Gilliam, and Sherman County, focusing in on 3 questions. What experience have you had getting translated labels and interpreters at your pharmacy? Do you have suggestions for pharmacies to better serve people who do not speak English? And do you have ideas of how to spread the word so that people know they can ask for a translated label? Next slide. So to summarize these 3 information from the 3 counties is in Washington, there seemed to be quite a few clients that were receiving dual language labels, but then again, there were also people that needed to translate their meds because they were only in English. And in the other counties, by and large, they were not receiving dual language labels, and that the staff in the pharmacies were not able to communicate in their preferred language. Their suggestions are that providers specify that patients need dual language labels, and some staff were encouraging nurse home visits to review prescription labels so that patients would understand after their visit to the pharmacy. Next slide. Slide. Okay, and suggestions, more education for pharmacies on how to get connected to interpreters. Again, requesting that providers be the ones to specify that patients need dual language labels. Next slide. A host of recommendations that are all around quality improvement, including more bilingual staff, better signage, digital tools, using pictures and icon, training for staff around cultural competency, around access to interpreters, etc. This is a very complete list from Washington County. Next slide. In October, we were invited to the Korean Community Group at Asian Health and Services Center. Next slide. There were 60 attendees there, and only 2 out of the 60 indicated that they received dual language labels. And the room just turned into a buzz, and people were applauding Kristen because they were so surprised to hear about this and so happy to hear that this was a law. And this is 6 years after the law's been approved. They expressed a high degree of discomfort and fear in reporting compliance issues to the board. And even though we volunteered to assist them, they were hesitant to do that, especially in today's environment. They did not want to rock the boat at all. They wanted their physicians, the providers, there should be guidance to providers to specify patients' needs rather than for relying on patient staff to request it. Next slide. We were also invited last month to the Asian Community Health Fair, where community members attended who speak Korean, Mandarin, Cantonese, and Vietnamese in partnership with OHSU. Next slide. Here our advocates presented, next slide, and talked, one-on-one with patients as they attended the health fair. We spoke to 63 Asian community members in their preferred languages. Next slide. We gave out dual language cards so that they could hand this to a pharmacist to let them know they needed dual language, hand it to a prescriber to let them know they wanted it ordered, that they need dual language labels. Next slide. These are homemade. They're not sanctioned by anyone, which we think would be preferable. So 90% of the community members were not aware that they could have dual language labels in their preferred language. Next slide. So in summary, with our different stops and visitations over the year, this slide kind of summarizes it all. There's about 10% of our population that needs and uses this service and follows and reaps the benefits of this law, but 90% of the people do not have any knowledge of this law and would like to. We are continuing some secret shopper, not so secret shopper data gathering where we go into pharmacies and talk to them about is signage there? Where is it? Are interpreters readily available? Do you utilize all 14 languages? Do you utilize dual languages at all? So that work is in progress. Next slide. Earlier this week, our OHA partners conducted a brief feedback poll at their pharmacy meeting on Tuesday. There were 35 patients, 35 pharmacists present. 7 of them responded. In the blue box, I kind of summarized what their takeaway was. It's a small sample, but the pharmacists there were very happy that someone cared and was asking about the feasibility of implementation of this law. They want to do the right thing. They want to improve patient safety, but there are challenges with cost and technology. There are some vendor issues, technical issues that are not being adequately addressed. Cost is prohibitive for small independent pharmacies. And they would like to have some guidance, more guidance about how to successfully implement this law, perhaps some coordination and collaboration across practitioners and organizations to better support them. Next slide. So through our learnings, I've identified that we really would like sponsors for this work. We're just a small advocacy work, group doing volunteer work. Potential sponsors who believe would be the Oregon Health Authority, who has been very much involved with us, and then now the Oregon Board of Pharmacy. And Gary seemed very supportive and eager to support this work. So we're looking for that sponsorship. We have engaged community stakeholders from the Asian Health Services Center. We're going to be working with Latino Network, but there are a host of other stakeholders, including professional organizations that we would like to engage and welcome your input on that. Next slide. So who are we specifically? It's my own reminder, my time is up. So who are we? You've heard about Kristen and Brian. Kate and Bethany are also with OHSU, Carolyn and myself, and then we've recruited 3 other folks after our health fair, a pharmacist, and also 2 pharmacy students from OSU. Next slide. So let's take this quiz again. This is now a dual language label. The show of hands, can you tell me if you would know how to take this medication? Please note all the hands are going up. Dual language labels are extremely important and very necessary for patients who do not read English. So next slide. So thank you so much for this collaboration and chance to share information. Next slide. I wanted to share that we have an appendix. Next slide, just really quickly. There's some history about the national trend towards increasing healthcare accessibility, specifically dual language. Oregon is not the only one and not the first. We're right in there. About 6 other states involved. Next slide. Here's our Oregon law. Next slide. 14 languages are covered in our law. Next slide. And then this is the breakdown of languages in our state. Next slide. And the next 3 slides, and you don't have to, you can show all 3 one by one, but this is just a brief summary of a survey that the Minnesota board did around audible language labels. It wasn't just around dual language, but they gathered data around audible as well as Braille, as well as dual language. Next slide. And this slide just highlights why they did it. Next slide. And I wanted to highlight their recommendations, especially number 1 or 2. And they went in with the principle that all Minnesotans should have access to prescription drug container labels that they can meet, that they can read, so that they can understand how to take their medications. And number two, that audible label requirements should not add to the financial challenges and that small chains and independent pharmacies are facing. I just want to end with that. That's in the appendix, and we appreciate your time. Hopefully we have time for a couple of questions.
As Board President Joyce, first of all, I commend you for what you're doing in this huge public health issue that really needs, improvement. So personally, I did med reconciliation at Providence St. Vincent's, which is a large hospital, and I worked in the ED there. And oftentimes I would see foreign language speakers with their medications, and it was challenging for me. And so, however, what was satisfying is when I was able to get it right, and I could see, the smile in their faces that, hey, thank you for helping me, get this cleared up, and how I'm supposed to take this medication, and what the medication is, et cetera. So I see it. I saw it there for over 10 years firsthand at St. Vincent's. So I commend you for what you do. Looking at the recommendations, they're reasonable asks, there's some limitations, and you noted that as well, but I definitely commend you for what you do, because I saw it firsthand for over 10 years. So thank you. Kirkbride, do you have any you wanted to add?
I don't have any additional comments. Very well said. Thank you.
Does anyone else want to ask or any comments or anything? Okay, Board Member Smith, did you?
Board Member Smith, no further comments at this time.
Board Member Kroger.
Kroger, thank you both for taking your time today to come speak with us. And I think one of the challenges with the way the current law is structured is the inability to use non-OHA registered individuals. I think that's huge. I early on in my career in Wisconsin was one of the Spanish speaking pharmacists. Would I be qualified under OHA to be an interpreter? Absolutely not. But I also had a number of technicians who spoke Spanish as well. So I think that's one of those limitations, and I understand the need for a registered interpreter who understands, various medical complexities. But I also think that when it comes to the speed of having oral interpretation, being able to leverage individuals who, English may be their second language, but they are, working in the pharmacy and they have those other skills. And I think advocacy really needs to go into having that updated or carved out for pharmacies so that they can leverage the staff that they have, but also having the professional discretion to go, this does require somebody with more skills in healthcare and medicine to be able to provide that. And then, hand it off to an OHA registered provider. And I think the financial barriers and the technology barriers, I think that crosses all sizes of pharmacies, large and small. Those financial challenges are not only for small independent pharmacies. While they may feel it differently than larger pharmacies, it is impactful for all. We do see large companies bankruptcy, in some of those cases as well. So those financial pressures are not limited to just the small pharmacies, but I think they're obviously more profound in a smaller pharmacy as well. But really appreciate this and continuing to be advocates for this and the patient awareness. And I think the same thing, having providers lean in, right? I understand that somebody who may not speak English as a first language might be hesitant to ask or can't even ask because they, so I think that advocacy is really appreciated, but I think the advocacy really lies on how do we have more people allowed to provide translation and interpretation.
I think we should get back to OHA about that, because our focus really is on the translated labels. Interpretation is already federal law. And what our hope is that if somebody, if a pharmacist can't get an interpreter that works for that patient, that at least they'll have a label that they can read. And when they get home, they'll be able to take the medication accurately. I think the other thing that I just want to mention is that in the law is the protection from lawsuits for pharmacists. Only if they subscribe to these vetted services that translate labels. And so that was asked for by the Board of Pharmacy when we we're passing this law. We had a lot of lawyers get involved because trial lawyers weren't too happy about that, but we did get it in there. And so the idea is that, if pharmacist is doing due diligence with finding, accurate translation, that they should not be held liable.
Board Member Schitt, thank you so much for your presentation and your dedication to having people speak dual language. Is there going to be a move to change the legislation from 14 to the 5 most common languages in the area that the pharmacy serves?
That is not something that we have moved on, but it is a consideration. And another consideration is the suggestion that pharmacies be able to select the top languages that they support based on their community. So,
And I think that makes sense to me, to not require something that they'll never see, and have to pay service for. Is prohibitive, but really being able to buy into who they're serving and work on doing a whole lot better service with being able to just focus on that, not have to think about. Yeah, really don't. Just one sit or top, and then are you working with provider groups and medical groups and others when they write their prescriptions? That please print in dual language. I mean, that's one of the instructions to pharmacists in your electronic record makes a lot of sense.
Eric,
Well, just that we totally agree. We would like to, we've reached out to the Primary Care Association, Providers Association, ONA, the nurse practitioners, and OMA. And we're just starting to gear up to connect with them because yes, it's important to know that as much as we believe that a provider writing that in the prescription is going to help, there's no reason a family member can't request the translated label. The pharmacist could recognize if somebody needs one. So it's not just the providers, but they are
We all
critical.
work together though.
Yes, exactly.
If we're all working together,
Right.
I think we're going to get better plans with solving patients.
The other thing I think I just want to point out is the 14 languages are approved every 10 years by Oregon Health Authority, recognizing that the Board of Pharmacy, you're not as experts on languages, right? So there are people at OHA that are. That list of 14 languages was not the most common languages. It certainly included them, but we took 3 different data sets. One is the most common, the other is Medicaid, the languages for Medicaid patients. And then the third was refugee data, because what we recognize is like some of the more common languages in Oregon, like Japanese, often folks that speak Japanese in the state often do have English speakers in their community who could help them read their pill bottle. People who are just arriving that are refugees, like Burmese, Swahili, some of those languages, those are actually the most vulnerable people when it comes to making medication errors. Their children haven't learned English yet to read the bottle. So we really wanted to take all 3 sets of those data and come up with a list that would also identify languages that are representative, particularly vulnerable people.
the provider engagement that you mentioned is very important. That is our next stop. I know Dr. Parks is starting to make those connections. But for a lot of patients, it is, there's a lot of fear associated with asking. So I think if we can get our providers, on board with that, I know it's another thing. We've also talked about working with Epic and other systems, health systems that already have predefined SIGs. Yes, and some institutions already use those. So that if it's in the database that a patient's preferred language is there, it automatically denotes that on the prescription, and that's what we need across the board, something that makes it easy.
One point I also want to make about signage, the Board of Pharmacy has, we provided them with a sign that any pharmacist in Oregon can download it and put it up in their pharmacy. They don't have to spend the money to make that sign.
Or video, yeah, okay.
How far down in Oregon have you gone? Because I'm from Southern Oregon and very far Southern Oregon. And I noticed a lot of the counties were from up here. All of them are from up here. So I'm from Klamath County. And I noticed that a lot of the data was from this part. Do you guys have people that are going into like rural Southern Oregon and other places that are also working on this?
Information from the Oregon Health Authority, they have staff and resources throughout the state. The 3 counties that I shared were ones that had provided responses, so we need to follow up with the other representatives. But apparently the state is covered with the OHA representatives, and we need to follow up to make sure the message gets out.
And I do want to commend Herbert's comment, because Spanish is my second language, but the medical terminology test for a license to be a Spanish interpreter is very different than the Spanish that I speak, or that most technicians that you would find in a pharmacy speak. Mexico is very similar to the US, as in different places that you are from speak Spanish differently. And so the way I may speak something from Zacatecas or from Nayarit, someone in a different part of Mexico will speak it differently. And so when you learn growing up, the medical terms and how you tell somebody to do something are different. And a lot of times with Epic or with any of the other medical systems, they will translate it into our system. We use McKesson Enterprise where I work. And so if the prescription says 1 tablet by mouth once daily with alternating something, when we type it one time in English, the second translated sig, if there is an off, like if it has an en, which in Spanish would be translated to en, the system will change it to in each nostril. So it doesn't, you have to catch that. At that point, most pharmacies would have to call a translator to then tell them how to type that out, versus using the person that is there that can fix it, because of the way the law is written on who can interpret. So I could interpret it and rewrite the sig, but I don't count. I don't qualify as a translator for my field, because I don't have that medical certificate, even though I could easily do that. So we use our hospital translator, and she laughs when I call. I'm like, can you translate this for me? And she's like, you already know it. Yeah, but legally, I have to ask you first. So it's those things that not all systems translate it equally. And there are some systematic errors that pharmacies do face when it comes to the label switching to adding both directions on it. So there are a lot of little hiccups in this. And I think one of the biggest things is you have to have a license to be a translator, regardless of whether that is your home language or not. And the medical cost behind getting a translator certificate is very high, and the testing for it is a lot more intense than what a medical background for somebody in pharmacy would be. Like, I obviously don't need to walk my patient through a heart transplant or surgery. I need to tell them to take it once, twice a day. And the pharmacist says it's for blood pressure, and the pharmacist says this, or the pharmacist is telling you that. And do you have any questions for the pharmacist? Like, those are conversations that you can have, but I'm legally not allowed to. I think that's a lot of barrier, even if you have more technicians or more associates that speak that language in that area. The law prohibits us from doing those translatings without getting in trouble by courts.
You know, we've definitely heard this issue. And this is an issue for the Oregon Health Authority who really pushed for this law for qualified of course, we want our interpreters to be highly qualified, right? But it is a limitation and a barrier, and we've definitely heard about that. And we'll get back to this group that we're working with about that. But in terms of translated labels, there's at least three companies that we have worked with that are national companies that do integrate with pharmacy software. The last I looked, it was about $100 a month for the 14 languages. But that is one of those vetted companies that supposedly is going to do a better job than you're describing, but I don't know. I hope so.
Overall, good job.
Overall, thank you. That was really eye-opening. I don't have any additional comments, but I really appreciate what you guys are doing.
Patel, are you? Can you hear us?
Board Member Patel, yeah, thank you for this presentation. And I'm going to just echo what Board Member Kroger and Board Member Pinedo mentioned, that yes, number one challenge is like, even though I might speak three languages and my mother tongue is Gujarati and the Hindi, but even though there are so many times I have patient and I cannot help them, the only reason because it's required Oregon Health Authority interpreter, right? And then also like you always have that risk, right? What if someone complained, right? Then you're like, well, why you take a risk even though you want to help the patient? You know that I'm a healthcare professional. My mother tongue is Gujarati, and then I speak Hindi. Still, I'm unable to help that patient just because I'm not Oregon Health uh, certified interpreter. So that's the piece is real challenging. And number two, challenging is if you talk about like it's not practical in real world that interpreter service available during the operation hours. It's like you have to make an appointment. I mean, you have to make an appointment. You have to make sure like when your patient is coming, when then you have to make appointment with interpreter service. And sometimes it's a huge thing. It's just because when they have the patient available, the interpreter service, they don't have the person who speak that language, and then vice versa. When the person has it, the patient is no show, right? And so at that point, what are you going to do as a pharmacist? You're not going to give a prescription, right? Or should you give the prescription and try your best to explain to them, right? So those are the challenging, like I can see in the real world. The other one is like absolutely financial burden, because like per our I don't know, I'm pretty sure if you work with Oregon Health Authority, you know the significant financial burden on the pharmacy side, and special independent pharmacy often they operate on narrow profit margin due to reimbursement pressure, DIR, increasing operation costs, and there is no reimbursement, right? So here is like another one, like when you say like $100 per month to put on the label, that's $100 per month. That's 24 months. There's a 12 months, 24. There's a $1,200 on the top. You have to pay the interpreter service, like let's say $25 per month, right? And I'm going to say another $4,700. And then on the top, there is also about $3 per minute for that service you provide, right? And then when you book, if it's no show, they still charge you. So everything, like I do personally believe that every pharmacist and every pharmacist, of course, we want to help the patient, right? But then we have to work on those barriers. I think then we can definitely provide the service better to all the patient. Anyway, thank you.
Thank you, Aurora Patel. We need to wrap up, but just I wanted to add a couple things. Just to piggyback on that, it's like the federal public health funding, as you know, is decreased and continues to decrease, and that that adds some financial burden on pharmacies and the community. But when I did MedRec, when the patients came in with their own foreign language after visit summaries from their providers. That is the best case scenario for us because they're able to read off the after visit summary from the provider. And with our interpreters that we have on screen, we can get a better reconciliation of the medications that way. So they have AVS from the provider, they have their medications there. We have an interpreter. And so personally, myself, I've seen it over the years. There's been a dramatic improvement, but it still needs way more. Way more. We still have, there's still issues that need to be, addressed. But thank you. This has been really eye-opening and informative. I really appreciate it. Thank you so much.
Thank you.
Now we will continue rulemaking policy discussion regarding drug compounding with staff member Aframa.
Staff member Efmoff, just give us one moment to get set up, please.
Smee Gustafson, can you come off of mute? Just confirm that you can hear us and you can speak. Natalie? Well, she's on the call and I unmuted her. Unmute her right away. We can go through the presentation. All right, Natalie, we'll come back to you.
Staff member Efmoff, we will start the presentation and then we'll dive in.
Wait, did that work?
There we
Sorry,
go. Yes. Hi, thank you.
did that work? Can you hear me?
Yes, we can hear you great, Natalie. Thank you so much.
Fantastic. Okay, great.
Thanks for joining. All right, we are now going to transition to discuss compounding rules. Go ahead and go to the next slide. As always, we start every policy discussion with our mission to help us guide us through the conversation. So you can see the mission up there. Move to the next slide. So we are also welcoming and introducing our subject matter expert, Natalie Gustafson. Natalie has been a compounding pharmacy owner and educator for over 16 years. Patient safety is at the heart of her work. She has owned and operated multiple compounding pharmacies, ensuring strict adherence to Oregon pharmacy regulations as well as federal standards, such as USP 795, 797, and 800. Also FDA, DEA regulations related to pharmacy sterile and non-sterile. And she also is nationally accredited through PCAB and Gates inspections. So a big thank you to Natalie. She has helped serve on the work group for a very long time, the compounding drug work group. And she also has assisted in these last revision cycle of rules. And when we get to the rule policy discussions, we'll ask her to give a little more input and thought on some of the discussions that we're having today to help facilitate. Moving on to the next slide, please. Again, this is just helping us triangulate why we're addressing this. So the rules prioritization list was adopted in April 2025. The board placed drug compounding in the high priority category. So this is why we are reviewing today, and we are amending the drug compounding rules to also ensure consistency with updated USP chapters that are going to hopefully meet the initiative for the board to develop rules that are clear, that they improve compliance and longevity in alignment with the board's mission to promote and protect the public. Again, just revisiting the division vision so that everyone is aware. You can see the board adopted this in 2022. We talked about this at the October board meeting for PPL, but this is just a friendly reminder that Division 45 is set to go away whenever the board does adopt potentially new rules, and it will be a whole new division as 183. So for today, context is always critical in conversations, and it's helpful to know where you've been before you decide where to go. So this is a reminder to board members, your resource folder includes all information reviewed as part of previous board discussions on compounding used to create these rules. That includes work group meetings, board meetings, and public comments. You also have been provided information on Washington and Michigan's Board of Pharmacy processes for accreditation and inspection standards for compounding that is also readily available on their public websites. For the public, all of the previous work group meetings, board meetings, and public comments are included in all the public meeting mailings and are posted on the board's website and available for up to 2 years. So if you're interested after this session to be able to go on our website and look at all of that information. So in this presentation, we're going to revisit the history of the rules in a very brief, condensed version, and then continue the epic journey to address where the board left off at the October board meeting. So in the presentation, we hope to complete by pulling up at the end of this presentation, we will complete by pulling up the proposed compounding rules and beginning the rules policy discussions. Staff will highlight the changes per board direction and areas for policy discussion. So the goals for today is to provide information to assist in clear understanding of what edits to the rules have been made and why, and to aid in review of the proposed rules. After the proposed rules have been reviewed, staff is hoping to receive board direction and determine what next steps are set for the rules. It's important to share that staff has continued to hear from the public and licensees the need for rules to be expeditiously updated. We want to respect those voices and determine the best way to continue moving the process forward and determine the best process to do that. Staff would like the board to have a conversation about the best way to get public and licensee feedback on these rules. The board has discussed a variety of approaches recently, and obviously there is no one-size-fits-all method. Each rule set is unique and may call for different processes to gain appropriate public feedback. With that said, we have opportunities to try different approaches, or if an approach at this time would be moving to rulemaking to get public feedback, or if the board wanted to try a different process or do additional updates at the February board meeting, these are all options you have at this time. I did also want to remind the board, as a friendly reminder, that at the August board meeting, board member Kroger had provided some input on how California asked for feedback outside of their official rulemaking process. We could at some time create a similar format to elicit public feedback in a requested form that aids for ease of review. Of course, that we could not require that, but we could strongly encourage it. Also important to keep into consideration staff resources when doing that process and how much time it may take to do that, but staff can always provide feedback on those methods and if they are an administrative burden for staff, but we would keep you informed. So there is one additional update that I wanted to make sure to include today. It's important to note that staff believes there are updates coming to USP. So it's our understanding that 797 was open and a new edition of an official updated form will be available as of 2/1/2026 for 797. For 825, it's currently open for comment period that will close on 1/31/2026. So this may affect if the board would like to send to rulemaking today. We would recommend if you are moving in that direction to hold until the February board meeting. We could give you an update on where those landed. Our SME can touch base on also that they aren't substantial, significant changes that we are aware of that would cause a need to do a deep dive change of these rules. They should be minor. So we could still continue our discussions today. It shouldn't affect that, but that we should bring this back to February before sending to rulemaking, because we would hate to send to rulemaking and then have to do another version, then thus going back to rulemaking, because that would be a significant difference. All right, next slide. So a brief history on these long history of these rules, I guess, for drug compounding rules, the board utilized a work group to develop and revise these rules. The work group was comprised of 4 pharmacists, 2 technicians, and 1 public member and 2 board members. The 4 pharmacists and 2 CPTs had backgrounds in community and health system pharmacies and in non-sterile and sterile compounding. The work group met 5 times in February, April, May, June, and July of 2023. As a reminder, a work group is a public body and is subject to public meetings law. The work group represented the interests of persons, communities, or entities likely to be affected by the rule. They provided advice and insight on specific topics and proposed rules related to those topics. Then board staff, upon the input from the work group, added the patient safety lens and drafted rules and modifications to the proposed rules to provide to the board, and the board made additional edits. In June of 2023, the board sent these rules to rulemaking for public comment only. meaning not intending to adopt these, but just to get feedback. Based on public comment and further work group input in July of 2023, board staff made additional further modifications to the proposed rules that were provided to the board. The board reviewed, discussed, and proposed changes to these rules at the April, June, August, and December 2023 board meetings, February, April, and June 2024 board meetings, and also was reviewed as of recently in August and October of 2025. So these rules have had a long journey. At the October board meeting, the board provided direction to staff to apply USP standards to the rules for any of the parameters outside of USP standards to provide a compelling reason why it is needed. And this will be our focus of what we're going to address for today's presentation and part of our policy discussions for the rule set. Next slide. As the board contemplates compliance with USP standards, I thought it would be very helpful for everyone to ensure that we are on the same page of what USP is and what USP is not. So this is just a high-level summary. It's not all-inclusive. USP is an independent scientific nonprofit organization with a public health mission. They do not have enforcement capabilities. USP defines the minimum standards to follow the preparation of compounded products. Again, crucial preparation of compounded products for humans and animals. This does not encompass how a prescription or a compounded preparation must be dispensed. So, for example, both 795 and 797 reference labeling requirements for the actual compounded product itself, not the dispensed prescription or prescription order. It also does not state who may perform what duties. The law, or ORS, dictates the practice of pharmacy, and compounding is within that definition. So the laws and rules dictate who may perform which function. For example, a pharmacist performing verification for tasks that require judgment. USP addresses what tasks must be completed or references when verification must occur, but they do not have the authority to define who the person performing that task is, as that would be dependent on the state-specific licensing authority and practice requirements. So again, the law revised statute would define the scope of the practice and the assistance of the practice. So the board will need to ensure that any rules put into place adopting USP still ensure that the statute is followed, particularly related to who is allowed to perform what tasks. This is important to keep in mind as we address what needs to be stated in Division 183 compounding rules for clear communication to licensees. USP applies to all persons and places where non-sterile, sterile compounding, or handling of hazardous drugs occurs, including but not limited to pharmacists, technicians, nurses, physicians, veterinarians, dentists, naturopaths, and chiropractors in all places, including but not limited to pharmacies, hospitals, and other healthcare institutions, patient treatment centers, and veterinarian or physician practice sites. So moving on to what types of USP we're going to look at today. So we have the USP 795, which is specific to compounding non-sterile preparations. It describes requirements for compounding process, facilities, equipments, components, documentation, quality controls, and training to promote patient safety. So examples of that compounded non-sterile product are solid oral preparations, liquid oral preparations, rectal preparations, vaginal preparations, nasal and sinus preparations for local application, and otic preparations. USP 797 is specific to compounded sterile product and is intended to ensure patients receive quality preparations that are free from contamination and are consistent in the intended identity, strength, and potency. It describes a number of requirements, including the responsibilities of compounding personnel, training, environmental monitoring, storage, and testing of finished preparations. Examples of compounded sterile products are injections, including infusions, irrigations for internal body cavities, ophthalmic dosage forms, aqueous preparations for pulmonary inhalation, bath or soaks for live organs or tissues or implants. USP 800 describes the safe handling of hazardous drugs to minimize the risk of exposure to healthcare personnel, patients, and the environment. While the National Institute for Occupational Safety and Health, NIOSH, defines the criteria and identifies the hazardous drugs, USP identifies the standards for handling these drugs to minimize the risk to the public. So their chapters include responsibilities of personnel handling, facility engineering controls, procedures for deactivating, decontaminating, and cleaning, spill control, and documentation. These apply to all healthcare personnel who receive, prepare, administer, transport, or otherwise come in contact with hazardous drugs and in all the environments in which they are handled. USP 825 is for radiopharmaceuticals. This is also a subset of prescriptions falling under the control of the US FDA for manufacturing and marketing, and other federal regulation or regulatory authorities have control over certain aspects of radiopharmaceuticals. This chapter is intended to provide uniform minimum standards for the preparation, compounding, dispensing, and repackaging of sterile and non-sterile radiopharmaceuticals for humans and animals that occur as part of a state licensed activities. Of note, Division 42 addresses nuclear pharmacies, which is applicable to radiopharmaceuticals, and we need to do a major overhaul on this rule section. It has not been updated since around when I was born in the 80s, so that will come later on. But just to keep that in mind as we start moving this chapter. So the big takeaway for USP is the requirements of these chapters, when followed, are intended to minimize patient harm, including death to humans, animals, and patients. Next slide. So we're going to move into the policy discussions. I thought it might be easier if we just get all of the information out there, so then when we turn into looking at the rules themselves, it will help aid the conversation to make sure we all have the same information when discussing. So we're going to focus on, I apologize. We'll discuss the required accreditation or inspections. We'll talk about prohibited practices, labeling, and pharmacy compounding for a veterinarian, the non-food producing animals. Next slide. So for the board's consideration, does the board want to consider requiring accreditation or inspections by a board-approved entity for all compounders or some compounders, depending on where the outlet is located and the type of compounding that is performed? Questions really are, should all compounders be required to have accredited inspections or receive accredited inspections? Or should this only apply to sterile compounding? Or should this only apply to non-sterile to sterile compounding, which is what the drug compounding work group recommended? Or should this only apply to out-of-state compounders sending compounds into Oregon? Since we are able to perform in-person inspections in our state for in-state compounders, we will hold them to the standards of USP if and when these rules are adopted, and not all states hold everyone to that standard. So keeping into consideration that Oregonians would be getting the same standard of compounded medications wherever they are, if they are getting it from out of state or in state. Also, it's important to remember the work group did provide additional information related to non-sterile to sterile requiring accreditation. So not just an accredited inspection, but it's due to the inherent increased risk with that type of compounding, but there is potentially an argument to be made that all sterile compounding has potential risks that could also require further vetting by an expert or an accredited inspector, or a board approved provider or staff inspection that could ensure those safety parameters are being met. So when the board gets the opportunity to discuss this policy discussion, we felt it was important to also just share what some other states are doing. So there was additional information. I apologize, I don't think it went out until this week. Was it on Monday? Maybe the references of just what was on the what's on Washington and Michigan's websites. So really, it's just information talking about how there are some states that do have requirements for all out-of-state compounders to have accreditation or completed an approved inspection by an approved list. So both Washington and Michigan have this. And you can see on their website, if you go there, it's pretty easy to locate. So we understand not all states are requiring this, but there are some states that are doing this. So I wanted to just give that kind of balanced opportunity for the board when you're assessing this. Is there truly a compelling need for this? And if that is in alignment with how you feel you would like to land compared to other states, or most importantly, to protect Oregonians, which is the most important thing. Moving to the next slide.
Board received it on Tuesday.
Okay. So this is prohibited practices and carpet in the compounding area. So I do apologize, I cannot have the USP citations on a public presentation. So I am going to read a little bit to help everyone in the public be able to understand what the board is talking about here, so we understand what USP citations we are talking about. So for USP 795 compounding area, 4.1 states, an area must be designated for non-sterile compounding. The method of designation must be described in the SOPs. Other activities may not be occurring in compounding at the same time as compounding. This is the key part. The compounding area must be well lit and must be maintained in a clean, orderly, sanitary condition and in good state of repair. There should not be carpet in the compounding area. The key component here is this is a should, not a must. So if the board adopts USP, this would not be a requirement. It further states in 5 for 795, surfaces should be resistant to damage by cleaning and sanitizing agents. Floors in the compounding area should be easily cleanable and should not be porous or particulate generating. So again, these are shoulds, not musts. So when we think about what is in the best interest of patient safety, the work group had recommended creating this as a prohibited practice. This was a very controversial topic. It's my understanding when USP had put this forth and then retracted. So there are many different things to consider. Our SME, when we get into the rules, will provide a little bit of input related to her experiences on this. But it also is important to consider for USP 797 in section 4.3.2, surfaces in the segregated compounding area should be smooth, impervious, free from cracks and crevices and non-shedding so that they can be easily cleaned and disinfected to minimize spaces in which microorganisms or other contaminants can accumulate. Again, this is a should, not a must. So just wanted to highlight those components for the board as you get ready to have your discussions. Next slide. Similarly related, a prohibited practice that was proposed by the work group is animals in the compounding area. Important to note that 795 is actually silent on this matter, and 797 does talk about Section 3, personal hygiene and garbing are essential to maintain microbial control of the environment. Not sure if they have little scrubs for dogs or things that you can wear. 4.1, sterile compounding facilities must be designated to minimize the risk of airborne contamination of the area in which sterile compounding occurs. Proper design and controls are required to minimize the risk of exposure of CSPs to airborne contamination. So it's not necessarily 100% clear. Obviously, you would have to be compliant with all other USP requirements. And I guess there's an argument to be made, is that even possible to do when you look at all of it collectively, and would an animal be able to be in that environment and have all of those other criteria be met? But it is not clearly stated here. That's why we were asking the board, and the work group was asking the board to consider this as a prohibited practice. And the FDA is a bit more clear on this one. The FDA considers the presence of animals or the evidence of their presence to be considered in sanitary conditions. Next slide. Sorry. Policy discussion that the board will have today is related to the clarity of what is expected to be on a label in relation to USP and OAR requirements. So every compounded preparation must be labeled with certain identifying information. And as the 795 section 9 shares all of its requirements, there are musts and there are shoulds. So in doing the full analysis of what are all met where, might be potentially confusing to licensees to know which requirement occurs when. That is thus why on the policy discussion, staff had proposed kind of some broader language to clump all of the labeling sections together with some language. But again, I think it's important for the board to note, if you do choose to stay silent on this, the labeling requirements would fall to what are musts within USP, again, not the maze, for the preparation. And then when dispensing the prescription order, OARs would apply at that point in time for Division 41, 43, whichever. So we were just looking at this more of trying to make sure there's clarity to licensees of what is expected of them. But I don't know that there's a fatal flaw concern related to if you chose to be silent on this one. So we just wanted to kind of lay out the other bigger pieces of, there are a lot of shoulds in USP, but those would not be required. Do you mind going to the next slide too? And so again, for 797, section 13 is their labeling section, highlighting the same components of, and it is important to note that USP does have a one-liner in their labeling sections that say all labeling must be in compliance with the laws and regulations of the applicable regulatory jurisdiction too. So I think that's maybe even a nod from them too, that we understand that there are different labeling requirements in different circumstances. And if we can go to the next slide. And this is just showing the OAR. So this is the retail drug outlet pharmacy labeling. So OAR 855 41 1130. I am not going to bore you to death and read this. We can go to the next slide. This is just more to help everyone's on the same page information wise and for the public. Next slide. And this is OAR 855 41 62 70 for institutional drug outlets, the prescription labeling requirements. All right, so this will move us to the next policy discussion, which is pharmacy compounding for veterinarian non-food producing animals. This is outside of USP. This is actually a bit less strict, maybe related to, well, I guess I wouldn't say it's less strict, but it's USP doesn't necessarily talk about this. And this is an area that is a bit gray related to federal regulations. So from our understanding, what is being proposed is not necessarily in conflict with federal, it's just giving clarity to those for a compelling need that is out there. So it's important for the board to know that the intent of this is to permit in-office use or non-patient specific compounded medication for veterinarian use. There is a risk to this, but from licensees and veterinarians' input, the benefit heavily outweighs the risk in this situation. Currently, there are not enough FDA-approved drugs for animals. It is costly for drugs to go through the FDA approval process, and many manufacturers do not do this for animal drugs. Also, many human medications may be used or modified to be used safely for animals. So treatment options for animals could be very limited. This process allows for licensed veterinarians to work with registered compounding pharmacies to ensure animals in their care receive the medications that are necessary and that there are limited barriers to them accessing the drugs for the situations where the medication may be needed in office or out in the field. And it's not always reasonable for a veterinarian to know ahead of time if they are going to need all of those. I did also want to let you know that the Oregon Veterinarian Association has been a strong supporter of this concept throughout the iterations of the language of the rules. Obviously, this hasn't gone to rulemaking in a long time, but from my understanding, they were very much in support of the trajectory this was moving and being a bit more broad and allowing this opportunity. I did add to the actual rules that were put as part of the mailing. Part of the discussion was NABP's proposed model rules. I did want to highlight those are very specific and a bit more restrictive. Some other states like Ohio and back east have adopted a similarly situated NABP model rules, but understanding that as Oregon, we are a very different state. We are a very rural frontier state, and you might have different needs. So I just wanted to kind of give that balance related to why that was there and to just give that information. That's not that we're necessarily recommending that, but when applicable, always trying to give the board all of the resources that are out there. All right, next slide. So we're going to move to mailing G, Division 183 for rules review.
Okay, I'm gonna open this in Word.
Okay.
So if we start editing, okay.
Yep. And so staff member Efremov, one other point for today too, please feel free. We're going to have a Word document up so we can do edits in real time as we can get board consensus if needed. Again, it appears that if the board agrees, it might be best to bring this back in February after we see exactly what happens with 797, and we'll have a little bit better understanding where 825 is, but also to share, we know we're a little off on 825 also already and wouldn't want that to be the rate limiting step of these sets of rules moving forward. All right, so we're going to do a little orientation real quick to the public and to the board on what mailing E is. This is drug.
It's G, sorry.
Oh, it changed. I am so
It's
sorry.
G and two things. I amended the gray box.
Beautiful.
And so the line numbers may not match.
Oh,
I
okay.
need to know that.
Thank you for the heads up.
Yep.
So there was an amendment to the gray box. So the line numbers you have might not match completely to what is being presented at this time. The content there, since the mailing, there were two small updates. One of the numbers was wrong, I believe, in the general section. It was an 8 that should have been a 7. And also one of the versions was not right. And I think it was for 825 we needed to update. So just wanted to make sure you were aware of that. Everything else should be the same. Again, the lines might be a little different and the box is different, not to throw anyone off. Not trying to sneak anything in here. All right, ready?
Yeah.
Okay, so drug compounding division is 6, 41, 43, and 183. We'll be reviewing these proposed rules with edits made from the collective comments from August and October board meeting via the board direction. The staff has removed all of the friendly reminders and that robust language that was in the gray box. So it is a more condensed version at this time. But again, if the public would like to have access to any of those are all on our website. For the format, we're looking at Division 183. Staff felt it's easiest to continue to review this in a clean format since there is that major overhaul and structural changes being made. So this means everything is going to be looked at as bolded and underlined because it's all technically a new division. Staff has put new changes in blue. So if everything is going to be bolded and underlined, but if it's in blue, those were changes since the last time it has been seen. And of course, language that is being proposed to be removed would have a strike through in it. So after the review of these rules, we hope to get board's direction on next applicable steps. We can make changes in real time. Same kind of format we had for PPL. I'm going to review and read each section of the rules to orient the board and the public to the language proposed, then pause after each set to seek board input and comments, except for sections that are proposed to be struck. For those sections, I will pause for board input instead of going to each board member. So I will stop and do a round robin. Sorry, I forgot to say that. Each section I will pause and do a round robin so every board member can provide feedback. But for those sections that are proposed to be struck, I'll just open it up for anyone to provide feedback. With that, I think we're ready to get going. All right, so the applicability section, OAR 855-183-0001. Just a little bit set up for you. Paren and paren. Paren 1 and paren 2 got flip-flopped. Seems to have a better flow in this version. So that is why that is highlighted, just to articulate that those have moved spots. The language in those has not changed. Again, an important reminder for this section with the board's full division vision changes. There will be coming some other changes related to when we implement Drug Security Chain Supply Act, so the DSCSA, related to registration types. And at that time, we know that an outsourcing facility needs to be created. So currently we have outsourcing facilities under manufacturers. We're going to need to pull that out. But as the rules are written here today, they are in alignment with our other regulations. But we do know that we need to make some updates in future iterations. So for paren 4, A through D.
There's a comment on paren 3.
Oh, no, this is
Just
just
for us.
a revision. Sorry. So there is a versioning up here in paren 3. That version is usually the date that we access it. So it'll probably be updated then right before rules filing. We will update that to the date that we check to make sure that that is the right version of USC that is being implemented. And that hasn't changed in a very long time. So same thing there. So for paren 4, the work group proposed this language, and it is important to note that this language is a bit more detailed than what USP definition is. However, the items identified here are not in conflict with USP, specifically 1.4 preparation for approved labeling. This might be helpful to have this explicit information specifically to help licensees know what compounding is not. And this is what the work group had really pulled together to add some clarity. Also because of flavoring statute, that flavoring has been carved out of being compounding, we definitely most certainly need to keep paren D in this section. And what we had done structurally, we had removed the language of what compounding is not from preparation according to FDA labeling, because it didn't make sense to necessarily have there, and moved it up to applicability. So kind of the vision of applicability is having everyone know who is required, right? Like who does this section of rules apply to and who doesn't not apply to. So we're really looking at what compounding is and what compounding is not. And with that, I'm going to pause and do a round robin, starting with Board President Joyce on comments or thoughts or questions.
At this time, looking at this section, I don't have anything that really I need to address.
Thank you. Vice President Kirkbride?
No comments.
Board Member Smith?
Comments?
Board Member Patel.
Board Member Patel. So, okay, never mind. No comments.
Board Member Kroger.
No comments.
Board Member Chin.
No comment.
Board Member Pinedo.
And no comment.
And Board Member Hall.
No comments at this time.
Thank you. We'll move to the next section. This is Division 855-183-0005. And this is definitions. So compounding definitions are going to apply to several divisions. So we do propose to make sure that we keep the full in-depth definition in Division 6. What we're adding here, we believe will help provide clarity as most people are going to come to 183 to look for the definition of compounding. So we want to make sure that they know where to find that. So the language proposed as is only has a minor change here. So it says now phrases or definitions used in OAR 855-183 are the same as provided in Division 6 or as included in the USP standard adopted by reference unless otherwise specified. I did also want to note that as part of Division 855-41-1035, minimum equipment requirements already currently require appropriate and current standards adopted by reference for USP. So we do have another cross-reference section that does require, if you are required to or providing services that would require USP, that you are required to have that on site. So I will open it up for a round robin and start with Vice President Kirkbride.
No comments.
Board Member Smith.
No comments.
Board Member Patel.
No comment.
Board Member Kroger.
No comments.
Board Member Chin.
Comment.
Board Member Pinedo.
No comment.
And Board Member Hall.
Comment.
Oh, and Board Member Joyce. I'm so
Nothing
sorry.
to add.
Thank you. All right, next section. So this was formerly known as designation. So this is 855-183-0010. Staff is proposing to add some clarity and change the title to registration requirements. We also received feedback from the board that if we were what we were asking for and that it wasn't really clearly stated in what we were asking for. And it really was just identifying who is compounding and what type of compounding you're doing. There's a lot of reasons related to preparing for inspections, to be able to communicate with the public or have an understanding of what compounding practices are going on in our state that would be useful for public safety to have this information. And it also is in alignment with NABP model rules to have this information. So staff tried to rework it. In addition, the language reads as, in addition to all other registration requirements, a drug outlet that is compounding must update in the board online registration system if the drug outlet is performing sterile compounding, non-sterile compounding, or both. I'm going to open this up for a round robin so board members can discuss this, starting with Board Member Smith.
Member Smith has no comments at this time.
Board Member Patel.
Board Member Patel, I don't have any comments. This one for updating, yes, that's definitely, I think it helpful to the public and for the inspector too. But I think I raised this question, I think probably about 3 years ago when we were discussing compounding. I feel like sometimes, you know, you have a pharmacy and then they have the compounding pharmacy and the retail pharmacy. Now, I don't know how difficult that for board is, but I was hoping that we have a pathway because, you know, the compounding, they have the separate self-inspection form, right? And then retail pharmacy, they have the self-inspection form. So I was hoping that way we can just differentiate, like, if someone wants the two, and there's a chance that two individual, they are going to be in charge of two pharmacists, they're going to be in charge of, two different section of that pharmacy. And so I was hoping that if there is any way that we can separate out, license, yes, for the compounding separate, even though if you have the same address. I don't know how everyone feel. I don't know if that's fit over here. The future discussion, I don't know, but that's just a thought. Thanks.
Thank you, Board Member Patel. Just a follow-up question to make sure I'm understanding your comment. Are you maybe proposing that it's a special registration type for a compounding pharmacy? Like they would have a retail outlet and a sterile, like some other states require special permits, and we would have to look at that legally too? Or are you, maybe I'm misunderstanding, just to give a
Yeah,
little more
exactly.
detail?
Exactly. Like just other states, they sometimes they have like, if you're a compounding pharmacy, it's just like, long-term care registration, right? Like if the retail pharmacy, they are also providing long-term care, then as far as I know, like you have to have long-term care license and then you have retail too. So when you get licenses, long-term care and then retail pharmacy. So just like that, um, we have a different, the compounding pharmacies are different, their license different, their self-inspection. We already have the separate self-inspection for the compounding in Oregon, but everything is kind of like separate, just like other state they have it. And the reason is like sometimes, so when you are a PIC, right? If you have a PIC, then that PIC is only responsible for retail, and there is another pharmacist, they responsible for the compounding for that purpose. So I think you understand, right? They're just like other state having two separate.
Thank you, Board Member Patel. And maybe moving forward, or we can maybe ask that as a question to everybody after, if you want to incorporate it in your comments from here forward, and then we'll make sure we get around to everyone. If you are interested in having a separate registration requirement for a compounding pharmacy, so if you are a RP outlet, then you would need the RP and the compounding. And if you are an IP institutional outlet, you might need your IP and that compounding registration in addition to be able to do compounding services. So just want to plant that seed too, if everybody wants to touch on that in their discussion, and I will hand it over to Board Member Kroger.
Board Member Kroger, I'm not in favor of a separate registration. I think that seems additional work for the board and the outlet. Only comment I have outside of that is typically we have like must notify board within 10-15 days, something like that. I think that we should be here, or if this is referenced somewhere else, so it's, hey, you have to update us, and what is the threshold for you don't update us? Either you start or end compounding services, right? I think it's more probably important on the starting of the compounding services that it's updated with the board within X timeframe, but other comments.
Thank you. Board Member Chin.
Appreciate Board Member Berger's, I think that it needs some direction on that, but otherwise
Thank you. Board Member Panino.
no comment.
Thank you. Board Member Hall.
Member Hall, I don't think I have any comment. What was mentioned by Board Member Patel, I'm curious if I'm missing something. I just want to make sure we're covering all the different outlets and situations. So I'm open to hear more, but at this time, everything looks fine to me.
Board President Joyce.
Board President Joyce, I just want to, I support Board Member Kroger's idea of some kind of time frame requirement to register with the board in a timely manner.
Vice President Kirkbride.
I like the moving around of the words, even though there aren't a lot of different words. I do think it reads better. Regarding Board Member Kroger's comment, I also support having some clarity in there about when they date online. And then regarding Board Member Patel comment, I do not support additional registration. I'm just not sure how widely applicable that would be, that an entity would need two different PICs, and that seems burdensome for the entire category, for just perhaps limited use, and burdensome for staff.
This is Board Member Patel. If I can just answer, I think I'm not asking doing the mandatory, and most of the retail and LTS, right, long-term care, it's not mandatory. If you chose to, then you can do so. And there is a reason behind it. Sometimes retail pharmacy, they're not necessarily in charge of the compounding, but right now, if you have one address, then you can only get the one license, and then one license means you have one pet. So someone wants to, if you give an option like, hey, you have a choice and you can be a two pick, and that's the choice, right? And yes, it is additional burden, but then it's also additional revenue by having an extra license fee too. So that's just a suggestion. It's just because then the person who truly in charge of the compounding, they will take all the responsibility. And then because the way our rules work, right? We always put on the pick, and sometimes that pick is only for retail, and then there is also a compounding pharmacy. There is another pharmacist who is responsible for the compounding. That's what my intention is. Thank you. And as again, it's optional. Again, there's also revenue for the licensing fee too.
Thank you, Board Member Patel, for additional clarification. Board Member Smith?
Smith, no further comments at this time.
So at this time, I think it might be helpful if we can just see, is there consensus to add a time clarifier of when someone would need to update online? And I just want to, I'll start with Board Member Kroger already added it. I think Board Member Chin, you said you supported that. So Board Member Pinedo, would you support that? Yes. Board Member Hall?
Yes.
Board Member Joyce, I think you said would, and Board Member Kirkbride said you would, and Board Member Smith, would you? And Board Member Patel, would you support adding an update of when they would have to submit that information?
I'm fine either way. It's just because you're going to renew your license every year, right? So it's like, I mean, yeah, I'm fine either way. If you want to add that, fine. If it's not, it's fine.
So I'll open it up to whoever would like to maybe start the bidding at what would be the appropriate time frame. So we do have in our rules 10 business days or 15 for several reporting requirements. This might be something that's different. And there also, as Board Member Patel shared, that there is required information to be provided upon renewals too. So just want to put that all out there. And it looks like Board Member Kroger wants to speak.
How far in advance do typically board inspectors plan their visits? Like 3 months, 6 months, 2 years?
2 years technically, but the reality is that we have to check in because pharmacies close and open, right? So there is about a 4-week time frame. I'd say 6 to 4 weeks before the inspection, making sure that that place is still the same location. Who is the PIC starting to do your more honed in work about it?
I would say the 15 days, because then before that phone call is made, ideally, then they'll have that updated and the inspectors will have the information they need to prepare.
And maybe we could just go around and see if there's consensus for that. Board Member Chin?
If that's what works for board staff, it's fine with me.
Board Member Benito?
Agree.
Yeah.
Board Member Hall?
I agree. Are we saying business days?
Yes.
Okay.
Board President Joyce?
I would prefer 10 business days, but if consensus is 15, that's fine. It's just 10 days is like a common, common time frame for a lot of the pharmacy stuff. So
Vice President Kroger? Oh, I apologize.
Do you guys want it to be like within whatever number of days from the date of initiation or prior to
Or both?
or both?
initiation for me, all right?
So is this also not just, so I think the other question we'll get around to once we kind of nail this out is it when you're starting and when you end, right? So is it really just having accurate compounding updated information in the system within 15 days? And I'll hand it over to Board Member Kroger.
My thoughts on this are, it is more important to notify the board when you are starting.
Okay.
As opposed to when you could just naturally kind of stop. And that's, to me, it's yeah, it'd be great to notify us if when you're ending it, but it's more just are you starting some new compounding, are you starting to newly now compound? But But I don't know if it's simpler to just say, hey, but it's one of those things that gets a business, maybe they'll take a pause in compounding for 6 months or a year or 2 years, but they still are, actively maintaining their compounding space, even though they're not necessarily using it. I don't know. I'm not really care, I guess. There we go.
Does anyone have strong opinions on this that might help other board members make decisions? And I apologize, Board Member Patel, I can't see your hand, so please feel free to speak up.
Oh, no, thank you. As I say, like, you update like every year. So I do not have any strong feeling about we should do it or we don't. Yeah. So I'm fine either way. 10 days, 15 days, upon renewal. Because yes, that's also happens sometimes. You do pause. Let's say it's like some pharmacy, they're doing only non-sterile compounding and especially magic mouthwash, right? And they lost that oncologist who loves to give that, magic mouthwash, and now they're not going to do that. And they're going to, so it's like, I don't know. It's a compounding world is like especially for the non-sterile, it's happened that, you're making it, there's a shortage now, shortage resolved, you're not going to make it. So that's the only reason I was like, well, every year if you renew, I think that's fair enough, fine enough. But the other board member thinks like we should put that 15 days before you notify the inspector. I'm fine either way. Thank you.
Thank you, Board Member Patel. Board Member Kirkbride, it looked like you had a thought.
I think just the way that it reads currently, it is implied if we do go with the X number of days, if it says update within X days, if you're performing, that already implies within starting or within stopping. And I think, yes, we are probably more concerned about the starting piece, not the stopping, but I don't think we need to explicitly say starting or stopping because you're updating within X number of days if you're performing. So I think that covers it all the way that it's read to me. And I would support, I don't like having a bunch of different days for people to have to remember. So I like consistency. So if 10 is more common than 15, I would probably be more towards supporting 10, but I do understand the need for notice for inspectors, but I think it's difficult sometimes when there's all kinds of different timeframes to make sure that you are adhering. So I would be supporting the most common one we see in our rules.
Board President Joyce, so, I mean, I'm envisioning, could there be a possible scenario where, a facility or outlet started the compound, but they had not registered with the board yet as far as that they are compounding. And then so it's essentially, are we giving them 10 days until that time? I mean, if there was an incident within those 10 days, would it be, it would be problematic, right? If, no.
Remember, Kirkbride, this is not allowing them to compound or not to compound. This is just our awareness of whether or not they're compounding. So
Fine.
if there was an issue, we would be notified of the issue. So I don't think it changes anything as far as that. This is just increasing the board staff's awareness of who is compounding and who is not compounding. And to me, 10 days isn't, I think that's sufficient.
Yeah,
I'm not concerned about someone compounding for 10 days and the board doesn't know about it.
okay, so it's more of a notification.
I think that's the intention. And I think I saw Board Member Hall lead in. Maybe did you have a thought that you were about to share? Make sure everyone gets.
Member Hall, I was gonna ask the same question that Board Member Joyce asked. I don't think they should be sterile compounding before we know about it.
Yeah.
But then they should have the license by then. So I don't understand why we need to, they got the license, why do they need to tell us what they're doing? We already know.
So Staff Member Abramov, one important piece to know is this is back maybe to what Board Member Patel was raising. So when they get a license, they just get a retail drug outlet license. We don't know if they're compounding or not. So we could, as we start to talk about this more globally, it's something we could add as part of the applications for someone to check a box as a required field. If you're compounding, is it sterile or non-sterile? We can also add that to renewals so that then there is the opportunity. I think there is a lot of value in what's been shared also, that when you're in certain situations, you might be compounding a few days a month, but maybe you don't really think of yourself as a compounding pharmacy for non-sterile. It's a very different scenario than sterile compounding, where that is your focus, or it should be better be your focus, right, in all you're doing. So I think there's a lot of flexibility in however the board would like to do this. I think it's just typically maybe standard in how that if you read it without a certain days amount, that it could be interpreted also that you have to be continually, like there is no days that you have a grace period to notify. So without an actual date range of days that you have to get compliant, it could be unfortunately read to infer that I have to maintain in the system accurate at all times. So I think part of this is making sure it's clear to licensees what's expected. And what does the board want though? Do you want it just to be, and we could add, instead of in the board online registration system via applications and renewals, as opposed to within 10 business days? You have a lot of flexibility here. Staff member Efremov, you do not have to decide today. So we could leave this as is. Again, I think I'll hear from board members, but staff would highly recommend revisiting in February, so we can take all this feedback and you can think about it and we can work on, I think we have the clear, at least what I can communicate now, I feel like are the takeaways, is that the board is interested in knowing this, how we collect it, and what is the time frame that people are required to tell us, or how they tell us seems like it's very open.
Could we also find out, because I think some of our comments have centered around inspections. Is it impactful to the inspectors that they know ahead of time? Because if we're talking about on an annual renewal, we would lose that aspect. So hearing from inspectors, is this impactful and helpful to know before you go to a pharmacy that that's what you're expecting to inspect? Is that helpful? And I think that might help guide where we land as well.
And Stefan Brefront, I can share for you, it definitely is. Having that information is extremely helpful, knowing in what you need to be prepared for, because prepping for a sterile compounding inspection is much different than a non-sterile.
This is Board Member Patel, if I can chime in. You are absolutely right, Board Staff Efremov. And yes, Board Member Kruger, that is really important information so inspector can prepare. Because if you, just for example, so when they come to my pharmacy, we do only non-sterile compounding. But even though if the inspector, because it's a rural area, so they also have to book the room, and they have to do the travel plan, to be honest with you, whoever inspector come to rural area in Oregon. And instead of having 4-hour inspection, it can be 6 to 8 hour inspection. And I'm just talking about retail plus non-sterile. But if you think about sterile, then it might be a whole day. So that's what I was also kind of like raising the question. We should do that extra license so they can prepare ahead of time, but that's just my 2 cents that yes, it is extremely helpful. Thank you.
In the initial registration, is it not an option to select sterile and non-sterile or both?
Staff member not currently, but we are updating applications in a few months. As I look at board council, she gets to enjoy it also.
At that point, would this still be needed if, as you're registering, you would know then, right? Whether or not you're compounding one magic mouthwash now versus one in 6 months, you would still be considered non-sterile compounding, whether your records are on file, right? So as a pharmacy who does occasional non-sterile compounding during the inspection, that would be an option of, have you non-sterile compounded in the last 6 to 12 months, yes or no, or to have an option so that inspectors can see, no, they have, yes, they are non-sterile compounding, but they haven't had any active compounding within a period of time.
Yeah, staff member Efremov, that is definitely a valid point. So at the minimum, what would be known is that initially they registered as a sterile compounder, And then we would update, they renew every year, right? So we would get information annually. I think the only situation that would be lost would be those that are not sterile compounders upon initially applying and then might start sterile compounding within that first year before renewals. But that's probably a very small percentage, or I guess that's, how much weight does that hold in the considerations of everything that you're making here and how you'd like to articulate this for licensees, and also potentially the burden of also keeping track of another reporting requirement. And not only that, when it's another reporting requirement, we still have to do something with it. So as staff, we are still processing and updating. If they're required to tell us, it causes extra steps for us too. But again, it's what's in the best interest of patient safety to have what information. And I think the dream someday is to be able to share that with the public too, so that they would know where there are, registered sterile compounding pharmacies so that they can get the care that they need. So there is many considerations to be made as you look at this.
This is Board Member Chen. I think that what I'm understanding is it's really not as big a deal about the non-sterile compounding for either inspection or for licensing, but the sterile compounding is the big deal.
Staff member Efremov, that is true, but also important to know that when you're going to a pharmacy, knowing that you are going to have a normal pharmacy and a compounding inspection will add additional time to the inspector. So when they are scheduling, it is important for them to know how to schedule as best as they can, knowing that there will be additional time with anyone that is compounding or not. So knowing that is still important, but there's many ways that we could gather that information.
So, Board President Joyce, I think in terms of patient safety, we should know as soon as possible, obviously. My concern is, if they registered or indicated that they were compounding during registration as a checkoff box, whether or not they are actually compounding or actively, or there are huge gaps in between, we know that they are and must maintain standards. So my concern is if we didn't know until 10 days after, I ideally would like to know as soon as possible.
This is Board Member Chen. What is it adding? We're not going to go out and inspect them. We're not going to.
All right, but it's not the inspection portion. It's just
we're not going to do anything with the information
on file and we know whether they're compounding or not. I mean, if they didn't register as a compounding pharmacy and they're as sterile compounding and they had not indicated to us that they were
within 10 days.
That's what I'm trying. That my point is, I really don't even want to wait that 10 days. If there was an incident before they were able to register, and then or before they were able to notify us, I should say.
I just want to make sure, because we do have a board member that's remote and people virtually that are very interested in hearing this conversation. So if we are speaking, trying to keep one person at a time and make sure you're using your mic. So I think Board Member Joyce, Board President Joyce was speaking, and if others would like to speak next, if you could put your hand up. I do see a few. I think Council also maybe had something to say. So I just want to make sure we get everyone the opportunity to speak. Thank you.
Yeah. So I'm just looking at the optics of it. It's like if we did not know, right, that there were sterile compounding and there was an incident because of the 10 or 15 days, and there was an incident before that. That's a scenario I don't want to see because if there was patient harm done within a certain number of days that were allotted to them because we gave them a time frame to notify the board. That's a scenario I'm just trying to avoid.
That's good. And I want to make sure, I think it was Board Member Chin. I didn't want to cut you off. Did you want to go ahead and share what you were saying before so that everyone could hear?
This is Board Member Chen. I would assume that whether they notified us within that 10 days and a complaint came before the board, we would still handle the complaint just like we would had they not done so. So that's where I'm not seeing the gravity of that 10 days, because we're still notifying us isn't going to prevent something. Still going to handle a complaint either way appropriately, so.
Whether they notify us or not, that's your point. Okay, good. Overall.
Overall, if new pharmacy popped up and they started dispensing meds before they license, like, are they required to be licensed before they do that, or do they have 10 days?
Staff member Efremov, you cannot dispense, distribute, or, oh my gosh, dispense the 3 Ds. Deliver, wow, without being registered in the state. So that would be an unregistered violation.
It should happen before they do it.
Okay, I think board member Kirkbride, then Kroger, and then we'll stop by council for 1 second too, to make sure she can share what she has.
I just want to comment, it seems like we're getting hung up on the word registration, so maybe we should consider.
Application maybe?
So their license, their registration is separate from this requirement to report the activities that they're doing. Like, we're not saying this is a substitute for the license or that this registration to tell us what you're doing exempts you from any rules. It's two totally different things. And so I'm wondering if maybe the word registration that appears a couple times is tripping people up. Yeah.
Okay. Board member noted. We'll do that. Board member Kroger.
Registration requirements.
Okay.
Board member Kroger, this is a really in-depth conversation for this kind of small matter, but I think my intent or my vision for this, we don't necessarily ask all of our pharmacies to list out what services they provide, right? We're not asking, are you, check the box if you're doing immunizations, check the box if you're doing test to treat, check the box if you're doing PEP and PrEP, right? We're not asking them to do that. We could potentially, if it's just a simple checkbox, hey, like, this helps the public know what services you offer. When it comes to like the discipline or the concerns around this, to me, the requirement for updating the board on doing sterile or non-sterile is more of like, how do we remind the entity that there are certain additional requirements if you are performing those services. Like, don't just willy-nilly start doing non-sterile compounding, because right now, do you have carpet? Maybe you shouldn't have carpet, right? Have you put in all those considerations, because you do need different equipment to provide those services. So I think that's kind of the intent of the notification, is more of a like, oh, the board knows I'm doing this. Have I taken the time to think about all the other requirements that go along with this service? And you could go down the line with all the other services beyond just dispensing prescriptions that pharmacies may offer. And who knows, this could be a really actually bad idea, because now it snowballs into, we're going to ask them to notify us, check the box on everything, and it becomes this, spider's web of, cases because they didn't notify us. I don't know. I think in some ways, yeah, they should be updating potentially. I think we could also get public input on how this might actually land. But the 10 days or the once a year, I don't know. I think I need more time to really kind of digest the implications of having this type of requirement. But for me personally, it was just to remind folks that there are additional requirements if you're doing this.
Thank you. And I just wanted to make sure that we got board member council. Did you still have something you wanted to share, or?
Board member council.
Board member council. Wow. AAG Hunt. How about we do that? Board member council.
She does counsel us.
Yeah. I'll call me a board member.
Yeah.
You're the board member.
It's lunchtime almost.
I think, I was just actually trying to look at what our term is for the online, what is the online registration? Because I think if we just changed it to the board, like, whatever, it is, get rid of.
But that's,
Yeah, I think
that, you can't,
But-
it has to be vague because we're changing the name of it.
Staff member from up, we are probably going through a software change soon.
No,
so
no, I know it's not
that
that.
might not be helpful in that
But-
scenario.
And we use online for
To
everything.
update the board.
Sure.
So email, writing, not a form, it's just any notification.
Okay, so staff member from off, it seems like there are a lot of really great thoughts and conversations going into this. It is time scheduled to break for lunch. So I think what we can do is I have all the notes of where everyone had landed. We can revisit this as we come back from lunch, or we can decide to pause and talk about this in February, but we'll touch base, take lunch, think about it. and we can revisit then.
Can I just add one thing?
Please do.
Was, just quickly, was this recommendation from the work group?
So staff member Efremov, my recollection is that there was a days put in there when it was originally brought back to you in August, and that staff or board members had decided to remove that language. So we had put it as being more general, but again, internally, we did have the fear that without having a days, that it almost makes it seem like you have no grace period and notification. Not that you're allowed to perform these services unregistered, that is not allowed, but that you have the ability to take the time you need to notify the board in a reasonable time frame. So maybe even what I'm kind of seeing from some facial expressions at this time, maybe what we do is we pause this one, bring it back in February, and we could give you a couple options when we work with council on a 10-day supply or 10-day supply, a 10-day reporting requirement, a general initial and online form. So we can give you like 2 or 3 options that you can look at, and you'll have more time to think about it by then and decide.
Okay, thank you.
Awesome, thank you.
1 o'clock, is that, or, yeah.
Okay.
So we're breaking for lunch until 1 p.m. for the public to know. We will be back online at 1 p.m.
Yeah.
All right, thank you. Sorry.